Our next topic is Game Changer, Best Papers of Last 5 Years by Dr. Gurunath Murthy. At present, he is consultant anesthesiologist in South Australia. He is a fellow of Australian and New Zealand College of Anesthesia, and he has also done his European diploma in regional anesthesia.
Thank you very much, everyone. Now, because of this presentation, I missed my Gujarati meal yesterday. So, I promise, Dilip, I will hit it hard today with a good dose and through proper route. Now, this was a difficult topic for me because, how do I define a landmark paper? How do I define, what's a game changer? Most of the literature that we see every day comes from a Western world. How can we apply it into our practice, our setup? Let alone the variations between developed and developing nations. There are interracial variations, genetic variations, physiological, pharmacological, and anatomical variations. So it's a bit hard, so suggest just take it with a pinch of salt. And also, there are different subspecialties, general anesthesia, regional, chronic pain, ICU. So I've just chosen some of those which I like, so we'll go through that. So we'll start from down under. Now, this is one of the oldest gases, the anesthetic gases that we know. All right? But it unfortunately died at some point of time, but came back again into practice. So, round of applause for our nitrous. So, let's see who killed it in first place. Okay? Now, the premise was that it's a weak anesthetic. It inhibits methionine synthesis, DNA synthesis, vitamin B12 deficiency and folate metabolism is affected. It also kind of is associated with teratogenicity, immunodeficiency, infections, severe nausea, vomiting. And also, there was one new premise that, inhibition of methionine synthase is associated with homocysteine. And then that could cause, that was an independent risk for cardiovascular complications. So, the researchers assumed that there would be an increased risk of cardiac complications. So, they did this study, and with good number of about 2,000 patients, and they overwhelmingly said that the routine use of nitrous oxide should be questioned. So, the Western world, we all know, suddenly everyone stopped using nitrous. So, did it benefit or did it harm the patient? We talked about beneficence, non-maleficence. Now, literature can do both. So, we have to be very careful. What they also did was, they did this continued follow-up, and they did up to, I think, 5 years, 5.7 years, right? A median follow-up was for 3.5 years, and they looked at cardiac complications, and they said that it is associated with cardiac complication. So, the killer didn't, the killer was still free, and they didn't stop the torture, all right? But there was one silver lining there. The same group did a subgroup analysis, and they found that chronic post-surgical pain after nitrous oxide was less. There is something. So then started the nitrous bachao andolan. It unfortunately didn't come from India, though. But, some of the authors, they genuinely thought there is some benefit, acute and chronic pain. In acute pain, actually nitrous oxide use is equivalent to using remifentanil up to 0.17 microgram per kg per minute. So, a potent analgesic which is often forgotten. It also useful in preventing anesthetic awareness, reducing requirements of volatiles, and also this changes in the CNS hemodynamics, and there were some equivocal results. And these cardiovascular hemodynamic or other complications, are they truly significant, was their question. Now suddenly the killers become healers. The same group did another extensive study, called it as Enigma 2, and then they found it was very safe. All right? So, it did not increase the risk of death, cardiac complications, and surgical site infections. And, okay, it is associated with nausea, vomiting, and if you give antiemetic prophylaxis, you can take care of that. So, welcome back to the anesthetic world. But the damage was done. Okay? A recent survey was done in Australia and among our colleagues also, and they found that less than 10% have gone back to using nitrous. So, how much a literature can affect our life is very important. Now, another thing, this might be older than 5 years, but the story starts from here. Now, because a group of researchers thought that giving beta blockade prior to non-cardiac surgery in cardiac risk patients, they thought it is very beneficial. There was some questionable articles, but coming from a powerful source. So the ACC-AHA guidelines, they said universally, they came up with guidelines, and often we treat guidelines as protocols, a lot of people. And they started using beta blockers left, right, and center in non-cardiac surgeries with cardiac risk patients. But then this POISE-1 trial was done, and again from down under. So a multi-center across the continents study with large number of patients. It's one of the biggest RCTs I know. So they found that, yes, risk of cardiac complications is less, but it was associated with significant hypotension, bradycardia, and stroke. Now, for every 1,000 patients who were treated with beta blockers prior to surgery, about 15 patients were prevented from developing a non-fatal MI, 3 from coronary revascularization, 7 from new AF, but there were about 8 patients who would develop stroke and death. But it took quite some time for the ACC-AHA to realize this effect. So this is the power of the studies that come from powerful people. Literature word, be careful. But then finally, they did come up with a guideline. See, between 2008 and 2014, it took a while for them to realize. So, who started all these problems? This is not the Don you're looking for. He's still at large. Or he might be sitting next to you somewhere, so just be careful. Or it is not this Don either. But this is this man. Look how simple, how nice it looks. You feel like, anything coming out of mouth is, sorry to say that. I can't stereotype people's faces, but he's Don Polderman. All right, he's a cardiovascular medicine researcher in Netherlands. And in his trial, the DECREASE-1 trial, such a powerful outcome he showed. 91% reduction in death and myocardial infarction after beta blockers. And it was found to be a fraud. And then they retracted all his trials, 1, 2, 3, 4, and 6 decrease. Okay? So the bronze medal goes to Don. But, rogue researchers are not there. It's an Olympic time, so I need to go for the silver medal. So this is Joshimbo, the great pretender, the killer. Now, he was called a leading specialist for IV fluids. All right? So hydroxyethyl starch. And again, he was found to be doing fraud research. And again, he was doing research. Essential to cause harm in these patients, and it led to criminal investigations. Now comes the gold medalist. No, not yet. So the silver is shared now. Scott Rubin. Now, we talk about multimodal analgesia this morning. COX-2 inhibitors, fantastic, we thought, or we still think, despite his activity. And of course, who benefited? The company. Pfizer. They were not implicated in this trial, but in the time where millions of people used this drug, they made billions. Interesting how this world runs. And finally, the gold medal goes to Yoshitaka Fujii. Just with his granisetron studies on PONV, 47 papers had such an incredible, nice outcome. And statisticians looked into this and they said there's a 7 in a billion chance that this to have some statistical basis. And finally, he got the gold medal, but I guess he's in the jail. Now, the researchers were so keen somehow to reduce the cardiac risk, and reduce the risk of cardiac complications in non-cardiac surgery. Then they started to look into other alternatives because beta blockers went out of fashion. They wanted something else. So they looked into clonidine. So clonidine, what's the guess? Good, bad, ugly? Good? I'm sorry to say. All right. So it increased risk of hypotension and non-fatal cardiac arrest. Sorry, clonidine is out. Now, the same people also thought about aspirin. And there is also on statins. All right. So aspirins, they thought again it might be useful. No significant difference in cardiac outcomes, but increased risk of bleeding. So aspirin is out. Now, this is one of the common dilemmas that we face in our daily practice. If a patient is on warfarin coming for surgery, we have to balance the risk of thromboembolic episodes or versus bleeding risk, and we often push it across to the surgeons or send them to the cardiologist who can do the evaluation and do things. But we as perioperative medicine specialists, we need to do all these things. So what we used to do is stop warfarin 5 days, wait for 1 more day, put them on bridging Clexane or bridging low molecular weight heparins for 4 days on the day of surgery and restart the warfarin as soon as possible. Is that good practice? Is that what you guys practice, most of you? Yes. Yeah, so quite a few, yes. You don't have to. All right? You don't have to. Because bridging anticoagulation was non-inferior but associated with more bleeding. All right? So, use your own sense. You can use the CHAD, SWAS score and all those things, but in general, if patient is in AF, is on warfarin, you can omit the warfarin without bridging anticoagulation. Now, I thought I'll go for a nap. So those who are already having a nap, continue to do so. I can see 1 or 2 here. Okay. So this is the National Audit Project in UK, and the NAP5 was on accidental awareness. It's one of the largest studies on this topic. So you can look at those incidences. Interesting that we don't have any numbers from India, but this is what they got from their snapshot audit. Highest risk is with cesarean section, and when you use a neuromuscular block, you increase the risk of awareness. And it affects the patients badly, both in the immediate post-operative period and for a long, long time. And 40% of them are affected so badly. And 2/3 of these events happen at induction and at emergence. And they identified many risk factors, patient factors, surgical factors, environment factors, and there are some subspecialties which considered as high risk. Now, they came up about 65 recommendations. Now, this document is about, I think, 23 chapters and some 300 odd pages. So good luck. Go back home and read those. Now, Pallavi already talked about the recent changes, and this was one of the interesting things that came up, compression-only CPR. So what was the evidence? There were quite a few studies, and I chose this one. Now, initially started with an animal model, and then they have done human studies also on this. And again, the premise was that at least do something. All right? So, did they find any benefit or not? Yes, of course. They said there was no significant difference whether you do the conventional CPR of ABC or CAB or chest compression only CPR. There was no difference in the outcomes. So, the resuscitation guidelines Pallavi already mentioned. Ideally, in hospital, you do the conventional one if possible. But if there is any reluctance to mouth ventilation, start off with chest-only compression. And there were arguments for and against. I won't go through this in detail, running out of time. But in general, there were quite significant arguments for compression-only CPR. But there are some particular cases that you need to keep in mind where compression-only CPR doesn't work. In-hospital cardiac arrest, drowning, pediatric patients. So please keep that in mind. Finally, the CRASH-2 trial. What is CRASH-2? Anyone know about the CRASH-2 trial? Tranexamic acid, yes. So, I'm sorry if it is not visible very well, but it's again a very large study giving tranexamic acid in the early period of trauma or a road traffic accident. And what they found was if you're given early, within 3 hours of trauma, there was risk of bleeding and death was low. But if you give it later, it is more harmful. So keep that in mind when you're going to give it. That's all, folks. Thank you.
I think only Guru could have done justice to this. He's my best critic. Yeah, I said only he could have done justice to this topic, and that's why it was given to you. And you really done a good job. I think.